I think with that, that pretty much segues us perfectly because it's 11:02 on my end. So good morning, good afternoon, hopefully not good evening, wherever you're tuning in from. Thank you for coming to this month's Coast to Coast chat put on by Prostate Cancer Foundation Canada. My name is Austin Zimmer. I am the support services manager for the foundation, and I'm delighted to have Dr. North here presenting the new era of PSMA scans and PSMA-based treatments, prediction, predicament, and promise. I'll now hand it over to Dr. North to introduce himself, and we can get on with the show.
Thank you very much, Austin, and thank you for the invitation to spend some time with you today. I'm a medical oncologist based in Edmonton, Alberta. I work at the Prostate Cancer Institute, and I'm a professor with the Department of Oncology at the University of Alberta. So I do hope that you're all having a lovely day wherever you are. It's going to be 23 degrees and sunny here in Edmonton, so it's perfect weather for a hockey game tonight against Dallas, so you can all cheer for us. And what I wanted to talk about today, we were bouncing some topics around back and forth, and PSMA scans and certainly the new therapy with PSMA, Lutetium PSMA, has been a lot of discussion amongst patients and as well in the press. And so it was thought that maybe this would be a good topic just to discuss. So what I'm going to do is walk through PSMA scans, what they are and how they work, but also a little bit about some of the controversies about them and some of the difficult situations that sometimes arise in interpreting them when men with prostate cancer may be having these scans done and dealing with their healthcare providers trying to make decisions. But really, I want to focus as well on the promise here because we now have a new therapeutic treatment for men with advanced prostate cancer based upon these PSMA scans and how we can use new drugs to give therapies to patients. So I'm just going to advance here. I do have some disclosures. I have participated in advisory meetings with various pharmaceutical companies, but I'm an equal opportunist. So I provide my opinion across a whole host of drug development, and I think that I'm pretty balanced in my opinion. However, I do really want to take an opportunity to really thank my colleague, Dr. Britta Danielson, who's a radiation oncologist here in Edmonton, who graciously lent me some of her slides from some presentations she's done before. So what I want to talk about is, number one, what is a PSMA scan and what is PSMA? Because we talk a lot about PSA, but these are not synonymous terms. And then I want to sort of just review some of our national guidelines about why you would do a PSMA scan, but also where you wouldn't necessarily do one, and how that sort of fits into men with prostate cancer. You know, which stage of prostate cancer would you really think that a PSMA scan could be helpful? But then I also just want to give a couple of very common clinical scenarios using fictitious patients that I've made up, where the PSMA scan information sometimes creates a little bit of confusion. And the reason I want to discuss this is because I think it's important that we all understand that there may not be one right answer with some of these discussions. And so men that might be seeking a second opinion from different doctors and getting different opinions, you might question, well, which one is right? And it turns out that no one is completely right or completely wrong because this is a new area. And just like back in the day when, you know, the explorers broke trail in Canada, you never knew what you were going to find. So in this era of brand new technology, you never really know what you're going to find. And then at the end, I want to talk about theranostics, which is a fancy way of saying we've got a new therapy where we can use this new drug called Pluvicto, Lutetium PSMA-617, to take the scan that is usually a diagnostic scan and turn it into a treatment. Along the way, if you have questions, feel free to enter them into the chat. Austin said he'll interrupt me if there's a question that comes on the fly, because sometimes it's nice just to get it answered at that time so that you can remember what you wanted to ask. So first things first, PSA versus PSMA. What is the difference? And I'm sure that everybody here is very familiar with PSA, prostate-specific antigen. That's a blood test, as we all know. And PSA is a protein that we can measure in a blood sample. It is created and secreted by both benign and malignant prostate tissue. And where the big controversies in PSA are in prostate cancer is in that area of screening, when you're taking healthy men walking up and down the street and trying to determine whether they do or don't have prostate cancer. But in an individual who already knows that he has prostate cancer, PSA as a blood test can be a very useful tool for monitoring the treatment response, whether you've had surgery and you're making sure that your PSA remains undetectable, or in the case of a medical oncologist who's managing somebody who's got more advanced disease, I can track that PSA trending to know whether or not the therapy that I'm giving is working or not. So that's a blood test. What PSMA is, it's called prostate-specific membrane antigen. And this little cartoon here sort of depicts for you what this is describing. So this is a prostate cancer cell on the right-hand side of the slide. And the blue little cartoon here represents PSMA, which is a protein. This time it's not floating in the bloodstream, but rather it's attached to the surface of the cell. So it's like a little marker that's hanging off of the prostate cancer cell. So you can't measure it in the blood, but you can do a special type of scan so that you can detect what cells in the body might have PSMA on them. So this is not a blood test, but rather it's an imaging test, very similar to getting a bone scan done, where you would inject a radioactive tracer intravenously and let it percolate around and then take some pictures. What we know is that about 80% of prostate cancers will show PSMA activity on their surface. So it's not 100%. So that's why if we're thinking about treatments that target this PSMA, what we're going to want to do is ensure that you actually have a cancer type that shows PSMA on the surface. There's no point giving a targeted therapy if your cancer doesn't have the target. You're basically going to waste your time. Now, this PSMA, it's a bit of a misnomer where it says specific, because there are also other parts of our body that do express PSMA that are nothing to do with prostate and nothing to do with cancer. Specifically, you can see this highly expressed in the salivary glands, so the things that give you saliva. It can be in your kidney, as well as in your small intestine. So this is important because those types or those organs will also show up when you do a PSMA scan, and the radiologist who's looking at the scan will know that that's normal expression of PSMA in a normal tissue. It's nothing to do with cancer necessarily. So that's the big difference here. PSA is a blood test. PSMA is a marker that's on the cancer cell and can only be looked for by doing special radiology tests, specifically through the nuclear medicine department. So this is where we come to the idea of prediction with a PSMA scan. And these are just some cartoons and some photos that I've pulled off the internet. So again, we remember here that PSMA is the target. It's the target molecule or the target substance that's on the cancer cell. So this is maybe a smallish print for you, but on the left-hand side here, this is where the diagnostic imaging comes into play. This is the test that the radiologist can do to look for your cancer. So PSMA is being expressed on the surface of the cancer cell, and then we tag to it a molecule that glows, a little bit of radioactivity, just in the same way that a bone scan is injecting a bit of radioactivity, and then it tracks through the body. So this is what we would do as a diagnostic scan. You can use any number of diagnostic tracers, and depending upon where you are in the country, one of the more common ones is a gallium scan, but we have different tracers in Alberta. They'll do different tracers in Ontario. So there's no one perfect tracer. But basically, I can create an antibody that sort of glues itself onto PSMA. And that antibody will be attached to a molecule that glows. So then I can inject the tracer, it'll percolate through the body, and then I can take a picture. And that picture then will tell you wherever there would be a cell in the body that would express PSMA. So it's like a bone scan in the sense of injecting a tracer and taking a picture with some radioactivity, but it's not just going to look at the bones, it'll look at everything in the body where there could be PSMA. So this picture that's sort of reddy pink on the right-hand side on the bottom, this would be a picture of a PSMA scan after the tracer had been injected, and then we take some pictures with a camera. And up in the head and neck area here, these are the salivary glands, so that's normal. Remember, that's part of the body that has normal expression. These are the kidneys, and they're lighting up strongly because they have PSMA and they're excreting the dye. But in addition to that, you can see all these little dots that are located elsewhere, which would be areas of activity where there shouldn't be normally PSMA, because that's not a salivary gland, it's not a kidney, and it's not bowel. So these would be areas where there was cancer that was expressing PSMA or metastatic prostate cancer. And when the radiologist has their special software, they could determine like what's a lymph node, for example, what might be an involvement in a bone, or if there was organ involvement in lung or liver. And they can do that, and they can give us a whole body picture. So that sounds fantastic, right? A one-stop shop, you can do one scan, it shows you everything. Well, there's pros and cons to this, and I'm going to walk through that a little bit. The biggest guidance that we have, every international organization and national organization like the Canadian Urology Association have guidelines that they put out to help guide physicians and nurse practitioners and others to figure out when you should do a PSMA scan. These are new technologies. They're not widely available like a bone scan or a CT. And part of what we have to learn is how to do these tests and interpret them. And this is always a challenge when you get a new technology. How does that sort of link in with the older technology that you have? And how can you be sure that you're comparing apples and apples when you're looking at tests? And that's sort of where one of our challenges lies. So from the Canadian Urology Association, looking at the medical literature, they've come up with some guidelines that are pretty similar to the international ones by the Americans or the Europeans. One of the places where they're useful is in the staging of men with biochemical recurrence after prior local treatment. So if you've had localized prostate cancer, and perhaps you've had surgery or radiotherapy, and then the PSA starts to go up, the question that we want to answer is whether or not that represents a recurrence of prostate cancer that's localized where the prostate was, or whether or not that could be more widely spread through the body. And that could have very significant implications as far as the treatment offerings that we can give to patients. We're not going to offer radiotherapy to the prostate area if it turns out that there are lymph nodes that are widely metastatic away from the prostate. So this has been the number one indication for a PSMA scan is in a staging investigation for a gentleman who's had local treatment before, but now his PSA is creeping up and we're concerned that he has a recurrence. So the big question is, does that help you as a patient? Does that help me as a clinician? Where it has its biggest effect is if you're hoping that everything is localized to the prostate area, then you might want to be very aggressive at a treatment directed to the prostate, whether that was further radiation or radiation after surgery that was done before, or possibly surgery if it had never been done previously. But you want to really know for sure if your problem is truly localized to the prostate area before you focus all of your attention there. So it can be very helpful in making decisions about whether or not you need further local treatment to where the prostate is. As a medical oncologist, my role in managing prostate cancer is more involving the drug therapy and more often in men with more widespread disease. And I would argue that we're not quite sure yet how the PSMA scan may influence some of the decisions that we make about medication therapy. So that's where there is still a bit of controversy. Another area where it may be considered is if you're newly diagnosed and a surgeon or a radiation oncologist is trying to optimally plan your therapy, they may want to use a PSMA scan in addition to other tests such as MRI or CT to really help give you the best information about your choices, such as surgery versus radiotherapy. The big thing for me as a medical oncologist is I use the PSMA scan in patients who I know have metastatic disease that is spread, who are also castrate resistant or hormone resistant because I'm hoping to determine if they may be eligible for this new therapy treatment, the Lutetium PSMA-617, otherwise known as Pluvicto. There is a bit of debate about whether or not I could use a PSMA scan to try to figure out what to do with men who are still in the hormonally sensitive setting. And that's where you can get differing opinions from people depending upon what they want to do. And you can basically find medical evidence to support your decisions one way or the other. So it doesn't usually help make decisions for men with hormonally sensitive disease, but in the hormonally resistant, where we're thinking about this Pluvicto treatment, these scans are critical. So that's sort of the nuts and bolts of what a PSMA scan is all about. These scans are not as widely available as a regular bone scan and certainly a CT scan. So the PSMA scan isn't going to be available at every center, even if that center does a bone scan, for example. So depending upon where you're located in the country, you may have to travel. But PSMA scanning is generally available in all the provinces, although it may be concentrated in some of the larger urban centers. Now, I want to present to you a couple of patient scenarios that have sort of come up more and more as we've been doing more of these PSMA scans that may cloud the water a little bit on that idea that this test is the best thing since sliced bread. Why doesn't everybody get one? So these are not real patients. They're composite patients that I've made up to try to prove my point, if you will. So the first one I want to discuss with you is a very common scenario that we see. A gentleman in his mid-60s, he's gone to his primary care provider for an annual checkup, and on his physical examination, he has a rectal exam, and the physician can actually detect that both sides of the prostate feel abnormal. His PSA is checked and it's 45, so it's significantly up. And he has a biopsy done, and it would be a Gleason grade group 4. That would be like an 8 out of 10. Now, he comes to us with the usual types of medical problems that often creep up as we get older. His blood pressure is a bit up. He's got diabetes, and he's got high cholesterol. And he's taking a diuretic, metformin for his diabetes, and a medication for his cholesterol. So this is very run-of-the-mill type of medical scenario that we would see in the clinic. But he feels completely well. This was all found by accident as part of his annual checkup. And he's sent for his regular scanning results, and he gets a CT scan and a bone scan, which are done to try to determine the stage of the cancer. And all that those scans tell you is that the prostate is a bit bulky, but there's no obvious evidence that that cancer has spread beyond the prostate. So we would consider this to be localized disease. It would be on the higher risk side of things because the PSA is elevated over 40, and that Gleason grade group is a bit elevated as well. But the majority of the treaters across the country would look at this scenario and would discuss with this individual that he should probably consider radiotherapy rather than surgery, and that he would then receive hormonal therapy in the form of an LHRH injection plus probably a drug like abiraterone, but for a fixed duration of time. We're not talking about a lifetime of hormonal therapy here. We're generally talking about 18 to 24 months worth of treatment for a scenario like this. However, because of all of the sort of interest in PSMA scans and the fact that depending upon where you are in the country, you may be able to go and get your own scan privately, he chose to go and pay for his own PSMA scan. Now, this is not him. I pulled a picture off of the internet, but it's basically showing you that the prostate is down here, which is showing activity on the PSMA scan, but it's also picking up some more distantly positive lymph nodes. So the PSMA scan has found this stuff on its test, which we did not see with the CT scan because the CT scan will pick up an abnormally enlarged lymph node, and a PSMA scan doesn't care what the size of the lymph node is. It can find very, very minute amounts of cancer just glowing in these lymph nodes. So as an oncologist, I have a number of questions that pop to mind. So the first question would be whether or not I would consider this individual to have metastatic disease or not, because that's a big difference between whether you think this is localized prostate cancer to the prostate or whether you believe that this is metastatic disease. And the difficulty that we have is that all of the conventional definitions of what constitutes metastatic disease are driven by the definitions of a bone scan and a CT. None of the definitions of metastatic disease included PSMA, largely because it's a new technology, so we would never have known what a PSMA scan would have looked like 10, 15 years ago. So the question is he localized or is he metastatic? That has implications for treatment. As a radiation oncologist, if you think that this is cancer that's beyond the prostate, are you going to offer radiation therapy? We were before the PSMA was done. Should we still, now that we know the PSMA? And then for me as a medical oncologist, how does this impact what medication therapy I might offer? Would I still offer a hormone injection? Would I add in an oral agent? Would I think about chemotherapy? And then the big question is, how long? Would I consider this to be a fixed time point where I perhaps say 2 years of treatment and then we take a break? Or am I committing this individual to lifelong hormonal therapy? And those are big decisions that have implications for quality of life. And then the big question, can I cure this patient or not? Excuse me. That's going to be something that everybody's going to want to know. So many of you may or may not know about this particular study that was done, and it's from the UK as part of their big program called Stampede. And what this study was looking at was for men with localized disease but considered to be high risk, what's the benefit of adding in an oral hormonal therapy like abiraterone compared to just using the injectable hormones and radiation? This particular trial was exactly for this patient that I pointed out. They were high-risk patients. They either showed that their lymph nodes were involved or they had higher stages of disease based upon their PSA and their Gleason score. So typically we would think that these people might need more therapy than perhaps just radiation, but we sort of intensify it with a bit of extra oral hormonal therapy. Now, that trial is a very positive study. It improves survival for the men who we give radiation treatment plus androgen deprivation plus abiraterone. And we do this for 2 years. So it's not forever treatment. It's just for 2 years. So you do your radiotherapy over the course of approximately 4 weeks. You take your LHRH analog injections, and you do that for a period of 2 years along with abiraterone, and then you stop. And just with that treatment program, you can improve the cure rate in people by about 10 percentage points. So that is very clinically important, and it would be something that would be done across the country today. No questions asked. And again, if we follow these plots out, some of, 80% of these men are still going to be alive 8, 9, 10 years out, even though they may have only taken hormone therapy for 2 years and then had the opportunity to come off of everything. Some of the men might have had to restart treatment, but many of them would have never had to restart any therapy. So the question that has been raised is, well, does this patient, what do I believe, the PSMA scan or the regular scan? And so they actually looked at men like this who would have met the criteria for this Stampede study, which was for men without metastatic disease. And then they looked at what would happen if you gave them PSMA scans by taking another group of men with similar patient characteristics, and they did PSMA scanning on them. And this is just the nuts and bolts of the study, which really isn't that important, except to say how they did it was they did a bone scan and a CT, and they did a PSMA scan, and they compared them. And they tried to detect what could the PSMA find that the regular scan couldn't. And what they showed was that up to 30% of patients would be detected to have metastatic disease with a PSMA that the regular CT and the bone scan didn't find. And at the end of the day, they thought that almost 90% of these patients who we have always said did not have metastatic disease might actually have something. So the PSMA scan has upstaged them a lot. But I circle back to this trial that I just showed you. This study is still a positive study. I can improve the survival in this patient population by giving them the hormone injection plus the abiraterone, but I only have to do it for 2 years. And this is the big difference between being a localized prostate cancer scenario versus an advanced prostate cancer scenario. If you have localized disease, it's a fixed duration of treatment, and then you stop and you observe. If you have metastatic cancer, you're basically committing yourself to being on medical therapy with hormone treatment for life. And as long as you're taking therapy, you're going to be potentially getting side effects. So then, this is where we struggle, right? And it has to be a real in-depth conversation with our patients, because if he was truly metastatic, I'm unsure. As an oncologist who's been doing this for 25 years, I would be unsure what would be the best therapy for this patient. Would it be to add on an oral hormone? Would it be even chemotherapy? Should I tell this man that he should be on hormone therapy for life, or should I give it just for the 2-year period? And how does that impact on his ability to have a good quality of life? Younger men are working. How am I going to impact his ability to continue to work? Even retired individuals still have often part-time jobs or lots of hobbies. They may want to travel. All of these things have significant impact on a patient. And it's important to remember that this man, this clinical scenario that I've given you, he may never die of prostate cancer. He may live long enough that he has another event, because ultimately we all have to die of something. So I don't want to be the cause of his mortality because of the toxicity of his therapy. You know, the longer you're on hormone therapy, the risk there is of things like osteoporosis. If we break a hip when we're 80, that's a big deal. So this is where we struggle a little bit, because you can look at this scenario and you can very easily justify giving this man some radiation to the prostate, as well as a fixed duration of treatment of hormone therapy of 2 years, and be justified. But if you believe, if you're all in on that PSMA scan, you're going to tell that patient that he should be on therapy for life. And you can, as a patient, be really confused by all this, because you could go to 2 oncologists and get 2 completely separate opinions, and they both are right. And this is why we're struggling a little bit in clinical decision making, and it really has to be an informed decision with people, the patient, the family, the caregivers, because we need to make sure that you ask all your questions and that we explain the pros and cons of our therapy. So the extreme scenario here, if I really want to push this, let's pretend that the PSMA scan found a lot of cancer, more than 4 spots. Well, I might actually suggest to that patient that he should get chemotherapy. Then we end up also taking radiation off the table. So my concern is that we may actually be taking treatment off the table by these PSMA scans that would really be beneficial. So it's a matter of under-treatment and over-treatment. And more often than not, with PSMA and the disease that it finds, we risk over-treating people and not necessarily even knowing whether or not they need it. And the longer that we leave people on treatment, the more side effects they get. So I just put a word of caution out there that we're still learning about these PSMA scans, and they're not necessarily gospel. So my thoughts about this scenario is I would try to give this patient the treatment that has been proven in medical research to be beneficial. I would ask the radiation doctor to treat the prostate, and I would offer 2 years of hormone therapy with both injectable and abiraterone therapy, but then I would stop and I would observe, because that individual may never have a rise in his PSA, and he may never need any further therapy. So I don't think in this case that I would let that PSMA scan change my opinion. And so in this scenario, it really wasn't helpful and it probably clouded the issues. And here's another very common scenario for the use of these scans. And I would argue that this is probably the most common place where we would use a PSMA. It's in a man who's previously been treated with surgical intervention for his prostate cancer, and then after a time period, the PSA starts to creep up. So in this situation, again, our mythical 65-year-old gentleman, he was found a few years ago on a screening medical checkup with his primary care physician to have a PSA of just over 6. He had a biopsy, and it's a grade group 3 disease, very common, like a Gleason 3-3, and he opts for surgery. A year and a half after his surgery, what was a PSA that went down to undetectable starts to creep up. Initially, it's 0.2, and then over the course of a year, it serially keeps creeping up until it's over 1. You can calculate this man's PSA doubling time, which we know is prognostic. The shorter the doubling time, the more likely it is that he has clinically important cancer. Anything under about 9 months, 8 to 9 months, makes us a little bit edgy. So he goes for conventional imaging with a CT and a bone scan. He's clear as a bell. This would be an indication to do a PSMA scan. So this would be one where we would order a government-funded PSMA scan. And because I'm lazy, I just use the same pictures. But basically, it's trying to prove the same point that we thought that it was going to hopefully just be in the prostate. But again, we find these lymph nodes that are outside of the pelvis. So what do you do? Well, I wanted to just highlight for you, in case you're not aware, that there's also some new data looking at this exact patient population and the role of oral hormone therapy with the drug that you're probably well familiar with called enzalutamide, which is an oral anti-androgen, one of the new generation drugs typically reserved or had been used in men with metastatic disease, initially castrate resistant. Now we use it in castrate sensitive. But this is another role for enzalutamide, which is in the patient who's got PSA recurrence, or what we call biochemical recurrence, after prior surgery or prior radiotherapy. So we look at doubling time, and we can't eyeball this. You actually have to enter all the numbers into a computer algorithm and let it tell you exactly what the doubling time is. But anything under 9 months is considered to be more rapidly rising, and it might be more predictive of the fact that if your scans look fine right now, they have a chance of developing metastatic disease in the near future. And that's actually been shown from some other research that's been done that shows that, for men here on this yellow-orange line on the bottom of this curve, if your doubling time is really short, it does not take long for your prostate cancer to go from just a blood test abnormality to something that you see on your images to ultimately being life-threatening. But if your PSA doubling time is really long, like 15 months or more, so it's just niggling along, your prostate cancer may never be an imminent problem. And so the shorter the doubling time, the more likely that we would recommend that you do something about that. And the cut point really seems to be if it's 9 months or shorter, that you're going to probably see a recommendation from a healthcare provider to do something if you're not taking any hormone therapy. That led to a big study known as the EMBARK study, and this is also a brand new treatment where we now are going to be getting funding for enzalutamide across the country for this situation. Basically, it's a busy slide, but to sum it up, these were men who had either had surgery or radiation. Everything went well, and then at some point in the future, the PSA starts to creep upwards again, and they actually have that shorter doubling time of less than 9 months. So we feel like we're probably going to want to do something sooner than later. We did a conventional bone scan and CT scan. We found no cancer. So this would be a patient group where often the recommendation would be to use intermittent hormone therapy. Take a defined period of time on your hormone treatment, your Leuprolide or your Zoladex, whatever, somewhere between 6 and 9 months, suppress that PSA, and then take a break. That was what would have normally been the treatment. And in this study, what they did was they compared that strategy of the leuprolide by itself, and then they added on enzalutamide. So they said, let's give you an oral hormone and an injectable, but we'll still give you the option of a break if after about 8 or 9 months your PSA suppresses.
Dr. North, just a quick
Yep.
question that came through in the chat. So a gentleman had just posted in wondering if they can do another round. So they've recently done their lutetium treatment. Are they able to do another round at a later date and that they've already done enzalutamide?
So I'll come to the lutetium therapy itself. The bottom line is that right now the answer is no. If you've done 6 rounds of lutetium, that's the maximum amount of lutetium that we can give, just based upon the fact that that's all the research that's been done in terms of safety and effectiveness. And basically, if an individual has had their lutetium and they are needing more therapy, it basically is, it's fair game for the treating oncologist to recommend anything that they think that might benefit the patient, whether that's another treatment like enzalutamide or another hormone, even circling back to chemotherapy if it was felt that that might be helpful. But at the end of the day, all of that is really done in the context of, experience, discussion with the patient, because there's no research that's been done that shows what the best treatment to give after lutetium is, because lutetium has been generally tested in patients who have had most of the other conventional therapies, and the lutetium was the last thing that they had on the plate.
Fantastic. And then one last question just came through here. This is regard to your recent talks here. Is this wondering if this is a different type of PET scan, and can it be used for targeted radiation treatment?
So yes, it is a PET scan, and the targeted radiation treatment is the Pluvicto, which we're going to talk about at the end of the treatment. So that's exactly what we're talking about.
Fantastic. I'll let you continue.
Okay. So in this particular type of scenario, this is the patient with only a PSA rise after definitive local therapy. What they showed in the study was that the combination of giving enzalutamide at the same time as the leuprolide, it's actually better than just giving the leuprolide alone. And it's not only better in the context of keeping the cancer under control, but it also helps you to live longer, but you get those treatment breaks so that when you're off of your hormone therapy, because you're doing things intermittently, if the testosterone is allowed to rise a little bit again, you get rid of some of those ADT side effects like the fatigue and the hot flashes, as well as the things that you don't necessarily see, like the loss of bone mass. So in this particular research, this has now been proven to be a very useful strategy that can help men compared to what we used to do before, which was just give them the leuprolide intermittently. So this combination therapy has been approved by Health Canada. It's been approved by the next tier of regulation. It's been agreed upon the provinces in terms of pricing. So now the last hurdle is that everybody's individual province has to list this drug for funding by your provincial cancer agency. Enzalutamide is not a new drug, but this is a new way of giving it in this new clinical scenario. So it has to go through all of these administrative hoops and hurdles. So the EMBARK study, which we use every day now to justify this combination therapy, but intermittently, shows what I just mentioned. You live longer, your disease is controlled better, but you also feel better because you get these treatment interruptions. But once again, somebody said, let's look at these patients and see what would happen if we did PSMA scans on them. Are they really just localized patients, or would the PSMA find things? And so the bottom line here is in the pink. 85% of patients who would have met the definition for that study that I just mentioned, where you can justify the intermittent use of this combination in not metastatic patients, 85% of patients have a positive PET scan. So that would mean, if you believe the PSMA scan, all of these patients, virtually all of them, are actually metastatic, and they are not just a patient with a positive PSA blood test. That would mean that typically we would not recommend intermittent therapy. We would suggest to you that you go on to your injectable hormone, a drug like enzalutamide, and you stay on it forever. For me, that is a very hard sell to give a patient the option of lifelong hormone therapy without interruption for a PSA of 1.2, knowing that the longer you take hormone therapy, the more side effects that you're going to experience. And I don't have any data that would suggest that by doing that and never giving him a break, that he's actually going to live longer than if I give him breaks. But I'm going to make his quality of life worse. So in this scenario, I ask at the second bullet point, did the PSMA help in this particular scenario? Well, the one thing that it probably might help with is that if we were thinking, could this man post-surgery have a little nodule of prostate tissue left over that the surgeon didn't take out, and maybe some focused radiation therapy might get rid of it? Well, in this case, if we knew that there were a couple of lymph nodes outside the pelvis, that might help to say radiotherapy probably won't be helpful. That's a good thing for the patient because radiotherapy after surgery is going to have more side effects than if he has radiotherapy alone. So I don't want my patient becoming incontinent or having rectal toxicity or any of the other things that could come from radiotherapy if it's not really going to help him. So it probably did help a little bit in figuring out that radiation wasn't going to be useful. Did it help, though, in terms of me being able to decide what the best drug therapy is? I would argue no, for the same reason as before. That I have a positive clinical trial that demonstrates if I have this patient scenario and I do this treatment, then I'm going to have a better long-term outcome, both from a quality and a quantity of life standpoint. But if I just throw the PSMA into it and just believe that he is a gentleman with metastatic disease, and therefore I'm never going to give him a treatment interruption, then the PSMA scan has not really helped me. And if I say, well, I'm just going to give him a treatment interruption anyway because I just feel like I want to because he's getting side effects, then the PSMA scan has not aided your decision making in any way, shape, or form. So I think we really need to be careful that we don't just necessarily buy in to say that the PSMA is always better than all the other scans. What we've learned in medicine throughout the years is whenever you get new technology finds things that the old technology doesn't find. So that's sort of the predicament. There's no questions that these scans are good. Like, as a friend of mine said, they can find a polar bear in a blizzard. They will find stuff that a CT and a bone scan didn't find. The question I will have, and I'll pose to you, is whether or not that disease that the PSMA found was necessarily clinically important cancer that was going to result in a quality or a quantity of life detriment for the patient. Because if you're going to live for years with prostate cancer side effects and may never die of prostate cancer, we have to be careful that we don't make the treatment worse than the disease. And we're struggling right now to try to do concordance studies between what does a CT and a bone scan mean in the context of a PSMA. And we've seen this before. Back in the 50s, when all we had was a chest x-ray, we only saw certain things in the lung. Then we get a CT scan. Now we find a whole bunch more in the lung, but we don't know what that means. Then we get an MRI scan. Then we get a regular PET scan. And every time we change the technology, we find and find and find, but the patient sitting in front of you is the same person. So I can take somebody who has a diagnosis of cancer, and I could do all 4 different kinds of tests on him, find a whole bunch of different results from those tests. But at the end of the day, my patient is still my patient. He didn't change between Monday and Friday just because I did a bunch of tests. So this is where we struggle, and this is the question here. What is the real truth? Which scan is the gold standard? And these are new scans, and so we're just learning, and we're just in the process of this. So I think the bottom point here is the most key. It's a balanced and shared decision-making where the clinician is honest and says to the individual sitting in front of him or her, there are pros and cons of doing any kind of therapy here, and there are pros and cons of believing which scan we want to believe. And sometimes it boils down to the personal philosophy of the patient in terms of what's your feeling about how aggressive you want to be, what side effects are you willing to tolerate. But at the end of the day, I think it's important to understand that you're going to get potentially differing opinions from differing people because there's no right answer. So just because one clinician says do chemo and another one says don't do chemo doesn't mean that one guy failed his exams and the other guy's bright. It just means that you have to acknowledge, if you're honest, that some of the studies that we've done that we use to guide our advice with patients, none of them were done with PSMA scans. And so if we just automatically assume that the PSMA scan is a better test, we're going to potentially make issues more difficult than they have to be. Don't want you to take away from this that I don't like PSMA scans. I do them all the time. But when you do it, you have to invest the time as the person who ordered the test in explaining the results with the patient so that you can understand the pros and the cons. And as a patient, if any clinician asks you to do a test, make sure you ask all the questions about the pros and the cons of doing the test, because once you do the test, the genie's out of the bottle. You have to look at the result and figure out what you're going to do with it.
Dr. North, just to interrupt you again. Another question from the chat. What is the difference between lutetium 617 and lutetium 177?
So I'm going to come to that later. They're basically just two different tracers.
Okay, perfect.
Okay. So this is now the new thing, the promise. This is the lutetium 617. So the difference between lutetium 617 and 177 is just the tracer that you tack on. It's the smart bomb that you tack on. It's just a different radioactive molecule, different compound made by different companies, and it has some slightly different activity in terms of the radiation biology, in terms of how much dose you give, how often you dose it. But they're basically both working off of the idea that they're lutetium. So you can't say, I tried 177, it didn't work, now I want 617. And in Canada, the only product that is licensed for use is this one that's on the screen here, the lutetium 617, otherwise known as Pluvicto. So this is the promise of smart bomb technology. So I think it's important here for me to just remind everybody what this stuff is just a way of giving radiation therapy, but you can give it as a IV instead of getting radiotherapy from the outside in, which is typically how radiation is given, where they only radiate one part of the body at a time using an external device. So we know that prostate cancer is an extremely radiation sensitive cancer, but the challenge we have is that it's very difficult to radiate the whole body simultaneously without getting a lot of side effects or even life-threatening problems. So this has been a limiting factor over the years, and that's what this technology is getting around. Right now, we know that if you are an individual with advanced prostate cancer that is spread, initially men are managed with hormone therapy, and that would be during a period of time that we would call that hormone sensitive or castrate sensitive. But eventually, castrate sensitive disease turns into castrate resistant, where the typical hormonal maneuvers don't work or are less effective. And our drugs that we currently use can include oral hormonal therapies. These are drugs like abiraterone or enzalutamide, apalutamide, darolutamide. There's a whole bunch of them. And then chemotherapy. And there are two major chemotherapies that we use in prostate cancer, docetaxel and cabazitaxel. But when you've tried the hormone therapies and you've tried the chemotherapies, we know that there are a lot of individuals out there who are still very fit, very well, looking for more treatment options. And that's where this drug therapy, Pluvicto, was tested initially. This is the trial that allowed us to get Health Canada to approve use of this agent. And it's also the trial that gets it used in the United States and in the European Union. It's called the VISION study. So this is the different things that we can do. So here, this again is the cartoon. You've got your prostate cancer cell, you've got your PSMA molecule, and then you've got your 617, and you've got your lutetium tacked onto it. So basically, it's a compounded substance where you're taking a molecule or an antibody that will grab onto PSMA, and then you're labeling that antibody with some radioactivity. And so the radioactivity in this case is the 177 molecule, and PSMA-617 is the glue that is the intermediary between the PSMA and the lutetium. When you do this, what you can do is you give the radiation therapy intravenously so that the radio tracer, now in this case the lutetium, which is doing the work, it can circulate through the whole body. So wherever there is a prostate cancer cell that is expressing PSMA, then the glue grabs onto the PSMA, and then the radiotherapy, the radiation, is delivered directly to the cancer cell. That means that you can give an intravenous treatment and you can simultaneously radiate the entire body with the radiation being accumulated in the cancer cells that express PSMA. So that's how this is different. The way the drug works, it's simply radiation, but you're able to radiate the whole body from top to bottom all at once, with all that radioactivity being homed in on the cancer cell. So it's a smart bomb technology. Therefore, it's important to remember that if the way that this works is you're delivering the smart bomb to the cells that have PSMA on them, then you need to test the person before you give the smart bomb technology to make sure that they actually have the target. Where is this drug currently used? Well, it's for men with metastatic castrate-resistant prostate cancer. They must have received a treatment with at least one of the oral hormonal therapy agents, enzalutamide, darolutamide, apalutamide, abiraterone, any of them. And they must have had at least one type of chemotherapy, whether that's docetaxel, or they could have had both if they've also had cabazitaxel. But basically, the important takeaway here is that it's not for men with newly diagnosed hormonally sensitive cancer, and all men who are eligible for this must have received chemotherapy and an oral hormonal therapy. And the final thing here, just you have to have the target, which is what I was talking about before. You need to prove that the patient has the target that the drug is looking for before you just give the drug. It's a busy slide, and this was just from the study, but basically the big key eligibility criteria I've already mentioned to you. You have to have a diagnostic PET scan. You need a PSMA scan that shows you have the target. You need to have had chemo. You need to have had an oral hormone, and you still have to have good blood work and good performance status. This is not a medication that we're going to give to people if they're hospice, or that we are going to give to people if they have significant problems with liver, kidney function, or their blood counts, because it can cause harm. So it is still for people who are pretty physically active, pretty physically fit, provided that they've had those other therapies, like the oral hormone and the chemo. What this study did was it randomly allocated people to one of two groups. One group was what was called the standard of care arm. Standard of care meant that they didn't get lutetium. They just received whatever therapy their clinician wanted them to have. So that could have been continuation of an oral hormone. It could have been steroids. It could have been purely symptomatic management. It just couldn't be chemotherapy, and it couldn't be another radiotherapy or radioisotope. So you couldn't get radium, for example, and be on the study. And then the other group received the lutetium injections, and the maximum number of treatments was 6, and there was no provision for retreatment. So based upon this study, there is no data for retreatment beyond the initial 6 cycles of lutetium. And to my knowledge, it's not being provided by any of the provinces in that context. You do your 6 treatments, and at that point, there's no provision for retreatment. To prove that people were eligible, they had to have that diagnostic PSMA at the beginning, and we can show that about 87% of patients have a positive scan. So very few people are going to have a PSMA scan that isn't eligible. So you may question, why do it? It's really important that we do it, because if you happen to have cancer on your PSMA scan that doesn't light up with PSMA, then this type of therapy will be completely futile. and therefore you could risk side effects from the therapy with no hope of benefit. But there might also be other therapies that a clinician might want to offer to you, such as different chemotherapy drugs or possibly other participation in different new drug therapy studies. So the bottom line is we really don't want to give the therapy to somebody if there's no hope of benefit. So that's why we do the diagnostic scan at the beginning to ensure that there's going to be hope of benefit.
To interrupt again, Dr. North, another question from the chat. Does it not make sense to proact and provide Pluvicto for locally advanced prostate cancer before it becomes metastatic and or castrate resistant? And do you see this being considered as a treatment option?
So that would be sort of the treatment paradigm of everything in prostate cancer, which would be that you have to test things first in this context and then you move it forward. So there are already research studies that have been done, for example, using Pluvicto in a patient group that have never had chemotherapy. So they may have been progressing on one oral hormone. And so then what we would do is test it versus another oral hormone before we get to chemo. But as you do those types of research studies, you have to actually prove the point and move it earlier and earlier. So I'm not arguing that it makes sense that you might want to test it in other clinical settings, but those trials and those research outcomes have not yet been established. And so we would have no data, no research that would show that the treatment could actually work. We have to remember, this is not a cure. So if you have a localized prostate cancer and you're hoping for a curative intent therapy, you would not want to offer people a non-curative intent therapy instead of something that could cure them. But if you're looking at other contexts, there's already studies that have been completed in castrate-sensitive disease. We're just waiting for the outcomes. The other thing which we need to not forget about is that this is radiotherapy. So there are long-term side effects of radiotherapy that we also need to consider, which can include things that affect your quality of life, as well as things that can cause more significant problems such as low blood counts with risks of infection and so forth. If you live with the side effects of a therapy longer, then you may develop more complications down the road. So we can't just assume that because it works in this area out here, it's automatically going to work here and be safe. So that's why we have to do the clinical trial so that we don't do a disservice to patients by just jumping in with both feet and assuming things, because when you assume, you can get into big trouble. This slide here, though, shows you that this medication can improve overall life expectancy. Many people were disappointed when they saw this, that they said it only improves life expectancy by about 4 months. I would argue that this is a patient population that has already had approximately 4 to 5 different therapies before they ever got to Pluvicto. So the fact that they were able to see anything in terms of survival was encouraging. And this amount of benefit is more than what was in the pivotal studies of the docetaxel regimen. And it's also on par with the survivals in the studies that we saw with drugs like enzalutamide and abiraterone. So everything is incremental gains. And possibly what we'll see as we move things earlier and earlier is that we will see a better outcome, but we just have to make sure that we do those research studies in a very methodical way, because when you rush, that's when you can end up with unforeseen medical consequences that can be dangerous. So we want to make sure, from a patient perspective, I know you'd like it tomorrow, and I would like it tomorrow as well, but the last thing I want to do as a clinician is something that could cause harm. From a side effect perspective, side effects that are most common: tiredness, dry mouth, because remember, it affects those salivary glands. And some people do get nauseated, and so our doctors will give people anti-nauseants to help. And not strong ones like you might need with certain chemotherapy regimens, but usually things like metoclopramide, which is the all-purpose one that you can use for almost anything. But it's very well tolerated. You do have to watch the blood counts, though. We do see people with low blood counts. This is a patient group that has also had chemotherapy before where they may have struggled with their blood counts. So the results of the study, it's a busy slide again, but basically what I would say is the dark green is the money slide. So it extends your life expectancy, it keeps the cancer under control longer, and it decreases the risk of having quality of life go down. It prevents you from having more pain, it prevents you from having a skeletal complication, but it's not a cure. There are some practical considerations that you need to remember, and this will vary from place to place, but every place that gives this therapy will have a radiation safety checklist. This is intended to be an outpatient procedure for the way that the drug is given. We don't admit patients to the hospital routinely to administer this. But that means that you have to be careful after you've received it, because technically you are radioactive for a few days. If somebody put a Geiger counter up to you, they would see that you've had a radiation therapy and that you're giving off radioactivity. So, things that are, easily workable, we say, where are you going to stay? Some people, if they're fully functional, they're going to be able to be in their own home and they're not going to need a lot of self-care. You would not get this treatment if you needed 24-hour nursing care and you were completely dependent on somebody else to do all of your care for you, because number one, you probably wouldn't be well enough that it would benefit you. But number two, you're going to radiate your caregiver. Can you use the dedicated washroom? We want you to sit when you void. We want you to double flush the toilet so that you make sure that you're not splashing urine around that might have radioactivity in it. We recommend that you stay away from any woman who is pregnant and any child who is under 12 for a week. So the grandkids can't come over. You can't sit around with your daughter and her third trimester of pregnancy and plan, the baby shower, because those children and pregnant women are more susceptible to radiation. So we take extra precautions for them. In terms of somebody living in the home with you, we recommend that you have a separate bedroom for a week. You would probably not want to travel in the car with them for a protracted period of time. And if you did, somebody's in the driver's seat, somebody's in the passenger seat on the opposite side. You can do that for up to a couple hours or more. But ideally, what you want is a 6-foot separation between you and everybody else for a day. So it's usually not a big deal. So we ask you, hopefully you can come to the clinic on your own. You can drive home. We don't want you on the bus. If you're going to be around somebody, we'd like you to have that 6-foot separation. And if you're still working, preferably to be off work for a week. Every clinic will have their own checklist. These are just some of the ones that we have. The radiation safety is important because we have an obligation to ensure that we're not going to put the public in a position where they could get inadvertently exposed to radiation. Some centers had said that they would admit patients for this therapy if they couldn't meet these criteria. We can't actually do that here at my facility because we simply don't have the infrastructure to do that. So patients must pass the outpatient test to be able to get the therapy.
Dr. North, just to interrupt you again, another question from the chat. And this is a kind of a general question, but are there any new drugs being developed to replace enzalutamide?
Not that I'm aware of. Enzalutamide is an extremely effective drug, and based upon the mechanism of action, there are a whole bunch of other hormonal therapies that are in that same space. But right now, they are working on some new mechanisms of action for some hormone drugs. But in fact, we were testing some and the studies were stopped because the drugs just weren't effective. And so right now, there's less of an enthusiasm for spending a lot of effort on hormonal therapies of that nature because we have many that work so well already and people are trying to move things beyond that.
And just one last question. Is the Cross Cancer Clinic recruiting yet for the study of actinium-225 PSMA? And are there patients eligible for actinium if Pluvicto treatment has been completed?
So the study is still ongoing through all of the regulatory hurdles. And so we are not yet recruiting, and that would be potentially the same across the country. I'd have to look at which particular eligibility because there's a bunch of actinium studies. Most of them will allow people who have had lutetium.
Perfect. Thank you.
So where is the future hold here? Well, we're hoping to move PSMA earlier, as was alluded to by some of the other questions. So there was a big study in Canada called the Pluto study, or PR21, where we actually tested lutetium. And then if the cancer progressed, we would go to chemo, versus the opposite direction where we would traditionally start with chemo and then go to lutetium. So we're going to try to answer whether giving it earlier is actually better. And then there's another big study called PSMA-4, where the study actually compared swapping out an oral hormone for another oral hormone. So let's say that you were on abiraterone and it wasn't working, then the study would compare enzalutamide versus lutetium. That particular trial was positive, so the US FDA did grant approval to use lutetium or Pluvicto in that pre-chemotherapy setting. That is not the case in Canada. It does not have an indication from Health Canada for that use, and it could not be given in Canada for that purpose. But like everything else, it's being tested earlier and earlier and earlier, and it's even moving, as I said, into that hormonally sensitive space, and most likely will move more and more proximal as time goes on. So the conclusions from my part of this, the sensitivity of how good a PSMA scan is, it will detect things that other scans can't. So it may be helpful if you're trying to ascertain what the best localized therapy is so that you don't offer treatment to patients that won't benefit them. But it's really important to know that there's been no medical research studies done with drug therapy, like hormone therapy, chemotherapy, etc., where the PSMA scan alone to make that decision has been shown to be beneficial. So we have to acknowledge that, because the biggest problem we face is we may be over-treating people with drug therapy that they don't necessarily need or which won't benefit them, but then they get the side effects. So that means that there's always going to be controversies, there's always going to be discussions, there's going to be differences of opinion. Not everybody, no one's absolutely right, no one's absolutely wrong. So it's a balanced discussion. But in the castrate-resistant setting, there's no question now that Pluvicto is a big improvement, because we now have another therapy choice for people post-chemo and post-oral hormones, with hopefully, if the studies are positive and show benefits to patients, it can move earlier and earlier in the treatment scheme. So that is the end of what I had to present. So I'm more than happy to take any questions that you have that haven't been answered.